Hello everyone, my name is Hillary McCutcheon, and this is my microbiology case study for the University of Kentucky MLS 401. Some patient history on our patient today is that he's a blind 65-year-old man. He lives on a small farm in rural southeast Iran, and he has some small livestock, specifically some goats, sheep, and a couple cows. He has a known history of COPD and had recently been diagnosed with an upper respiratory infection by his primary care physician. You'll often hear me refer to a primary care physician as a PCP. Some symptoms that he has is dyspnea, loss of appetite, and malaise. He complains of flu-like, cold-like symptoms, tired, weak, achiness, lots of general muscle pain. The patient was put on a broad-spectrum antibiotic by his primary care physician, and he should start to feel better within a couple of days. 1 week later, after seeing his PCP, the patient was admitted to the hospital due to worsening symptoms. He now has exacerbated COPD as well as pneumonia. Some lab testing was performed at time of admission. His CBC was relatively normal, 85% neutrophils, normal hemoglobin and hematocrit, normal platelets, no inflammation, at least according to his SED rate. Urinalysis was normal, chest x-ray normal, blood cultures and sputum culture was all obtained at time of admission. The patient was changed to a combination of intravenous ceftriaxone and azithromycin. Keep these antibiotics in mind as we move forward. So day 3 of hospitalization, we're approximately 10 days into having gone to his PCP and seeking treatment. So the patient is worsening. He has new onset of delirium. No improvement is noted in any way. The physician taking care of him wanted to do a lumbar puncture, but this hospital's policy would not allow him to because the patient had no next of kin and the patient's altered mental status. A repeat chest x-ray was performed, and you're going to note that he has right side angles that are closed, wide mediastinum, and opacities in the lower regions of the lung. So on the top here, you'll note a normal chest x-ray. You'll see the outline of the lung, and that's where you'll see opacities or fuzziness, for lack of better terms. On the bottom, you see out past the drawing of the lung, you'll see a darker opaque region. It's a little bit larger. The patient has worsening pneumonia. He's got more fluid in his lungs. He's getting worse at this time. So on day 3, the patient's blood cultures are reported for positive growth. They have growth of gram-positive streptobacilli. This picture here is kind of a textbook picture of the organism that we're looking at. Note that in a blood culture that you're going to have background interference, it's not going to always be textbook perfect. So day 4, the microbiology lab has a better understanding of what this patient's growing. There's a heavy growth on the blood agar, so all 3 quadrants show growth on your plate. It's a gamma hemolytic, creamy, coarse, gray colony with irregular borders. It's noted that it has a jellyfish-like or fried egg-like appearance. So the lab likes to do confirmation testing on this type of organism and wanted to do some additional testing to better know what they're dealing with. So it's a non-modal, endopositive, catalase-positive, oxidase-negative organism. It's suspect Bacillus anthracis. So their policy is to do some confirmation, and they want to do PCR testing to genetically confirm it. But they notify the physician, this patient most likely has Bacillus anthracis. You may want to adjust this patient's course of treatment. So the treatment plan was changed to a combination of penicillin, ciprofloxacin, and clindamycin. And according to the National Center of Biotechnology, respiratory anthrax has a 60% survival rate when treated with ciprofloxacin, clindamycin, and penicillin. So the physician put this patient on an antibiotic treatment plan that is its most likely chance of survival. So I told you to note earlier what the patient was previously on as far as antibiotics go. And he was on azithromycin and ceftriaxone. So Bacillus anthracis generates cephalosporinase, which causes it to be resistant to cephalosporins. So Bacillus anthrax was resistant to what this patient had previously been on. So ding, ding, ding here. This might be a reason why the patient's symptoms were worsening. You know, this patient was not ever on an antibiotic that was very effective to the organism that this patient had. So day 5, day 2 of treatment for anthrax, and the patient is getting worse. He now has jaundice. His liver enzymes are elevated. His hemoglobin and hematocrit, as well as his platelets, have all decreased. The patient is septic, and he's in respiratory distress. And this is all caused by the anthrax, which is making the patient worse. So the final outcome for this patient is that he eventually does die. Cause of death was ruled inhalation anthrax and sepsis. So no autopsy was needed to confirm this. It was very well known. So within 16 days of seeing his primary care physician for an upper respiratory infection, this patient goes from basically COPD, thinking he has a cold, to pneumonia, to sepsis, respiratory distress, and then ultimately death. Inhalation anthrax was confirmed with genetic testing, PCR testing, and a repeat culture, and was, of course, the cause of death. So some things I want to note that their public health department did is after his death, they did an investigation. And this was an isolated case of anthrax, but they wanted to know the source or the vector for the anthrax. So in the 1900s, anthrax was nicknamed the wool sorter's disease, and it was very common, or more common at that time, for people who worked with wool and leather and textile workers to contract anthrax. So this patient lived on a small farm in a rural community. He had sheep, he had goats, he had cows, he had livestock. Okay, so very possible, being an immunosuppressed, somebody with COPD with an advanced age, to possibly contract something like this. They investigated a possible unprocessed sheepskin rug. They thought, oh, this will be the source, but it turned out to not be. And the health department decided they couldn't find the source, but just ruled his cause of death to be most likely caused from inhalation of contaminated dust particles, which is all around, especially in a dusty area like Iran. That's all I've got for y'all. Thank you for your time, and I hope you learned a little bit more about Bacillus anthrax and specifically respiratory anthrax. Thank you.